medicine before EBM and after EBM. So what's the difference?
Well, the biggest difference is the way we use and process the evidence. And so in the talk that I just gave, I gave examples of the fact that we had evidence for thrombolytic therapy, clot-busting therapy after myocardial infarction. If we had processed the evidence properly after about a dozen trials in 6,000 patients, the evidence was clear that the thrombolytic therapy reduced death rates by about 25%. But people, the clinicians and the experts in particular, did not know how to process the evidence properly, and as a result, it took another decade and another 40,000 patients enrolled in trials before experts were finally persuaded. I gave another examples in the talk of when I was training 30 years ago and was in a coronary care unit. I gave out an antiarrhythmic agent to stop patients with myocardial infarctions having arrhythmias. I gave it out regularly to my patients. That's what I was told to do. In fact, the evidence from randomized trials, the highest quality evidence, consistently suggested harm, and they did many trials over a period of 20 years suggesting harm. We kept giving it, and finally clinicians stopped giving it. There was never any evidence in support from randomized trials. It was all biologic rationale. So we've moved away from a reliance on biologic rationale towards randomized trials and toward believing randomized trials. And I think, hopefully, and that for sure has happened, we also have become much more skeptical. So that another story that illustrates that is hormone replacement therapy. And most people in the general public know that for a decade, the experts were recommending hormone replacement therapy to reduce cardiovascular risk in postmenopausal women. Now, as it turns out, that was based on observational studies where you look at women who were taking hormone replacement therapy and women who were not, and those seem to suggest a reduction in cardiovascular mortality. But we now know that randomized trials in which people are allocated by a process analogous to flipping a coin to receive or not receive the treatment provides much stronger evidence. So, and when those studies were done, hormone replacement therapy either has no effect or possibly increases cardiovascular risk. And we were giving it out to postmenopausal women. The experts were making these strong recommendations to do so on the basis of this inadequate evidence. It turns out that the women who took hormone replacement therapy in those observational studies did do better in terms of cardiovascular risk. It just had nothing to do with the hormone replacement therapy. Women who took it were higher socioeconomic status. They probably attended to their health in other ways that were important, and that, in fact, explained the benefit. So the biggest way I think these stories illustrate is the way we treat evidence, the way we process the evidence, and the way we interpret it in terms of guiding our clinical practice.
Evidence in itself is enough, or there's more?
And I thought I had spent enough time answering your first question but I could have added another way things are different. There's actually a big irony, and that irony is that when we started around 1990, when we started introducing these evidence-based approaches, the label evidence-based medicine started to be used. We focused on what I've said up to now, which is the processing and how one interprets the evidence. But when you start doing this, when you start looking really hard at the evidence, and you say, okay, and you put numbers on it, the risk of myocardial infarction is reduced by this much, and the risk of bleeding is increased by this much, but it gives these side effects by this much. You immediately are confronted by the fact that there are always upsides and downsides to treatment, and that in a considerable number of instances, the upsides and downsides may be closely balanced. And then you say, well, what should I do? And that confronts you with the fact that evidence is never enough, that it's always values and preferences. And this has been, it may be extraordinary to think so, but this has also been one of the major revelations that right to this day we have some problems persuading clinicians. And I still remember and experts, and that has changed dramatically over the last decade. But the decade ago, I had the vivid experience of going before an important guideline panel and telling them that their decisions, that when they recommend something, it was based on values and preferences. Half the room was outraged. And they got up and said, we're not here to make value and preference judgments. We are the experts. We think we know the evidence, but we're not here to make values and preference judgments. And yet they were giving out recommendations. And my answer was, you don't want to make values and preference judgments? Certainly, then don't make recommendations. Tell people the evidence and leave it to them. But it really, and to this day, it is when I'm on the wards with doctors, the traditional way of training doctors is you tell the patient what to do. And when I'm teaching young clinicians, one of my challenges in teaching evidence-based medicine is to get them to see that the patient values and preferences are crucial. And just one story of that, there was one patient who hadn't been taking their medication for some reason and didn't seem to the house staff like the sort of patient who would. And this patient had atrial fibrillation, which increases your risk of stroke, and they thought this was a very bad patient to offer warfarin to because it's an anticoagulant. You need to get your blood checked every 2 weeks. You're at risk of bleeding. You have to be very careful with what you eat and so on. And I said, no, go ask this individual. And they went and asked, and they came back and said, this guy really doesn't want a stroke, and he's ready to go through all that. So it is. So the other revelation from evidence-based approaches has been that values and that evidence is not enough in itself. There are always trade-offs, and as soon as there are trade-offs, how you balance things like reducing stroke or increasing bleeding or inconvenience or cost, that those balances, that there are values and preferences underlying all those decisions, and we should, if at all possible, be using the values and preferences of our patients to ensure that they get the care that is right for them.